Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you for tuning into the podcast. Welcome. As always, I love being here. It's going to be a fun episode because today I don't only have one, but I have two guest speakers. True. Not really. I'm just kidding. I have a couple of reels I wanted to use with you guys. I'm going to respond to, and I'm going to start with them, and then I'm going to do my response to them. And there's going to be a whole episode talking about them.
Can you get bioidenticals or HRT without doing blood work? And the answer is yes, you can. There's a lot of companies that actually do this. But the question is, would you really want to? Would you really want to take a medication or a hormone without first checking to make sure that you're actually in perimenopause and that's what you need it for? Or finding out if it's hypothyroidism or anemia or a vitamin B deficiency or something like that.
So that's the first video that came out. And then another doctor came in and did her response to it. So I'm going to play that part now.
Can you get bioidenticals or HRT without doing blood work? And the answer is yes, you can. There's a lot of companies that actually do this. But the question is, would you really want to?
I'm so glad you brought this up. My name is Dr. Mary Claire Haver. I'm a board-certified obstetrician gynecologist, and I'm also a menopause specialist. For a healthcare provider who understands the endocrinology of perimenopause and menopause, testing is rarely needed. The diagnosis of perimenopause is clinical, meaning listen to the patient, believe the patient, and begin treatment. There is no definitive blood, urine, or saliva test that will diagnose perimenopause. Postmenopause can be diagnosed for 1 year without a menstrual period after the age of 45. Since there's no therapeutic range established for hormone levels for proper treatment, we treat symptoms, not the blood work. Save your money, ladies. You don't need these expensive, unnecessary, and not covered by insurance blood tests. You just need a practitioner who knows what she's doing, is going to listen to you, believe you, and begin therapy.
Can you get bioid?
So I've been sitting on that reel and its response for over a year, almost 2 years now. And I've been thinking about it. It's been in the back of my head for a year and a half now. The reason why I'm making an episode on it today is, from time to time, I get comments when I discuss lab work of people saying labs are not necessary. You don't need to do lab work to treat women. And they justify it and they fight me on that. Other times I have people with curiosity, like, well, why labs? What labs would you run? And what are the benefits of that? And why would you think that's important? And curiosity is way better than condemnation, as always. And I want you to know, I sat on these reels why I didn't want to make an episode on it is because both of those physicians are doing good work in the world. Both of them are. Both of them are. And they're working very hard at it. And they're working hard at making a change. And I admire that, very much so. It's important to communicate with you. Even though people are working very hard to do the right thing, there is risk involved in what they do. And when they do things a certain way, it creates more risk. I will never prescribe a hormone to a woman without a lab. And never. I think it's irresponsible to do that. Why? When a woman presents to clinic, perimenopause, menopause, doesn't matter, wherever they are, I need to understand her. I need to understand what's going on with her because that's basic medicine. We're required by law to do that. So that's subjective. That's me listening to you, giving me the information that you have that you're going through. And then it is my job to use objective measurements to understand how your symptoms are biologically occurring and just to confirm what I'm hearing and what I believe is happening. That objective data is lab work. In this case, in endocrinology, it's lab work. When a woman comes to clinic with perimenopause, you do run labs because of thyroid. Because it may not just be that she needs progesterone. And it may not be that she needs, estrogen or testosterone. She may need me to understand her a little bit better. So you have a woman presenting to clinic, she's 42 years old, perimenopause symptoms. Well, what else could be causing her symptoms? What else is going on there? She could be having insomnia. She could be having anxiety, depression. Well, those three things are very common in the perimenopausal state because of low progesterone. What else could be causing those symptoms? Tons of things. Thyroid, that's a good one. That other doctor, the first person starting the reel that Dr. Claire Haver responded to. That's important. That's doing your due diligence as a physician. So running lab work is important. And then what about when the patient comes to clinic and you have her on care? How do you manage it? Giving you hormones is not benign, okay? It's not. Anytime a doctor steps into that room and starts, interacting with you and begins to, engage in a therapeutic engagement with you, prescribing medications, specifically, that is not that's not just some blindly done thing. There's always risk. So if you prescribe a woman, say, progesterone, which is the most benign one we can prescribe, you have to understand, is this woman going to be a reverse responder? Is she going to go have an opposite response to it? Because that's a possibility. So you always keep that in your mind. Can you lab for that? Not easily, but there are things you can do to look into that. What else? You give her progesterone say you're giving her progesterone for anxiety. What if it's her thyroid? What if it's something else? What if it's a relationship? What if it's her spouse? What if it's work? What if she has PTSD? What if it's cortisol? Why is she not, and say you do run the lab work and she's low in progesterone, why is she low in progesterone? Is it because she is perimenopause and now she has luteal phase insufficiency due to the fact she's not ovulating like she once was, because that's towards the end of her, years of fertility? Maybe. What if her prolactin is elevated? You have to run that lab. That's part of being a doctor. Because what if the prolactin is elevated? Well, then you normalize that prolactin and that would see ovulation improve, hopefully. If it isn't, then yeah, you use progesterone. But you deserve us to understand you. Say I start treating you with estrogen. I know when I give you estrogen what it's going to do. I just know it. I know it. We have to know it. As a doctor, you're trained to do that. So I know if I give you estrogen orally, oral estradiol is going to have a higher conversion rate to something called estrone. I need to run that lab if I'm giving you orally. No matter what, I got to run that lab. Because estrone's an inflammatory estrogen. Now, you have to have it. It's a part of being alive. But if it becomes elevated, too high, it's going to be at a higher risk for developing clots because estrone stimulates thrombin. There'll be a citation right here. Estrone also is associated with breast pathology and breast cancer. And there's a study here for that. That's just two I just grabbed off the top of my head. Estrone's not benign. You have to have it, like I said, but it has to be in range and ratio, just like all hormones in your body. Some women absorb it better than others. If a man presents to clinic with symptoms of low testosterone, I could never imagine treating him without lab work. It's not accepted in medicine. Why is it then that when a man comes to clinic and he has symptoms of low testosterone, I have to run labs for him, but not for the woman? Why does he deserve lab work and she doesn't? When a woman comes to my clinic, I do listen to her and I believe her, always. I don't doubt her. That's not my job. My job is to take what she's experiencing and try and put it in context and help her understand biologically what's going on and then give her solutions. That's what I do. And it's a calling. We're here to be compassionate and to listen to them. So of course we listen to them and we care for them and we act upon their concerns. Then there's the talk of the money involved. The bulk of my labs are done through insurance-based labs. I don't use bougie boutique labs. I just don't. I don't have to. These are basic labs: LabCorp, Quest, Access Medical Labs if you want to. They all work well. You just code for it and insurance covers it. If you don't have insurance, I have other companies we can use. LabCorp has a pretty good discount program with us. Access Medical Labs has really good pricing too. Life Extension, it's a company that makes supplements, but they have really good pricing on their labs, truly. So there's things to look into. So cost shouldn't be the big issue, because this is not about profiteering. This is about caring for you. There's an argument that people make online with me where they say that, your lab values are constantly fluctuating and there's no known level it's supposed to be at any given day. This kills me. That doesn't make sense. Let me explain why. That sounded arrogant. I'm sorry. That sounded arrogant. I don't want to be arrogant. I want to be helpful. In order to be in this space with you as a doctor, it's essential that I understand how hormones move through your body daily, monthly. It's important I understand those rhythms and what it means when something's off. It's important that I'm able to interpret your symptoms and the labs and the timing of the lab being run with what's healthy. You're right when you say that your labs are all over the place and they're always different, but there's a rhythm to that. And the rhythm is supposed to be very specific. And if you're not following that rhythm, I need to understand why. I need to test for that. I need to figure that out and put it back into that rhythm, because when you're in that rhythm, you're healthy. When a patient comes to my clinic and we sit down with her labs, to her, it's going to look like chaos. It's not going to make sense. The word doctor comes from the Latin word docere, which means to teach. That's my job. Sit in the room with her. Say, okay, this is where your labs are. You're in luteal phase. Progesterone should be here. It's down here. Estrogen should be here. It's up here. This is why I think this is. This is what I think is going to help it. Start the care right then. Run the labs a month later. If I prescribed her a medication that's going to generate downstream metabolites, I run that lab. Because estradiol to estrone is a serious thing that's true and valid and it's real. What else could go wrong? Testosterone, my goodness. Testosterone should never be prescribed without lab work, but I see it prescribed all the time without lab work. And I see it also prescribed with partial lab work. If you're going to do testosterone, you have to monitor a woman's dihydrotestosterone. No matter what, you must. Because that's what creates the side effects. It's part of the job. Progesterone, a little more tricky. But if you have a woman who's swallowing the progesterone pill, more of that's going to be converted over to allopregnenolone than is maintained as progesterone. Now, here's the part where you have to understand labs. If you're running an ELISA lab with that, enzyme immunoassays, if you're running an immunoassay on that, you're going to see the progesterone is an amalgam. The result on that lab is an amalgam of allopregnenolone, pregnenolone, and progesterone, and other metabolites, lesser known metabolites, less essential metabolites are down there. So running that type of lab for progesterone, limited benefit. If you run thin layer chromatography mass spectroscopy lab for progesterone, you're gonna get the pure progesterone. That's pure progesterone. Why is this important? Because if I give you progesterone and I run not a very good lab, I run the at least a lower cost lab, I'm not gonna get the best results. I'm not gonna get a full understanding of how much progesterone is really in your body. And if I'm giving you estradiol, okay, your estradiol is up here, and I'm giving you oral progesterone, and the lab, the ELISA, shows me here, that's enzyme immunoassays. Anyway, the enzyme immunoassays show me progesterone's here. Okay, that's all right. But most of that, or a significant portion of that, is metabolites of progesterone. Why is that important? Because it's the progesterone that you need for the uterine lining. It's the progesterone that you need to protect the breast tissue. The metabolites are going to go up to the brain and make you feel great. And that's awesome too. We want that. But if I see your estradiol here, I need your progesterone here. Because it's your life and you're my patient. When a doctor doesn't run lab work, they court disaster in so many ways. And maybe it's only 1% of the population, or even if it's 0.1% of the population, that's enough. 0.01%, that's enough. Lab work. If it's too expensive, figure it out with your doctor. Needs to figure it out with you. Your doctor's job is to do everything possible to make this safe and work hard at making it accessible. We do that all the time. It's not hard. I run a busy practice and we still do it. We still help them. We still figure it out with them. I want you to know that, these two providers that I pointed out in these videos work very hard to help people. And I know their hearts are in the right place. I know this. I don't doubt that. That when they make videos like this or they approach practice like this, it creates a bad pattern and it sets a bad precedent and it makes people believe that it is acceptable for them to have less quality care than they deserve. I never want to be critical of people who are working hard to do good. It's just, this will cause harm. It just will cause harm. Without lab work, it will cause harm. It just will. There's no one who can argue this with me. None. And if they do, the first thing you have to answer to me then is, what do you do about dihydrotestosterone when you prescribe testosterone? If you're doing a topical testosterone and it's converting to dihydrotestosterone at a 5.5-fold rate higher, when you make a video like this, you challenge people, and sometimes it causes them to attack and be reactive. And I want to avoid that because the science that I'm standing on is solid. I promise you this is the science, okay? I hope this helps. I truly do. I do. To the degree it does, like my video. If you like the message I sent, you like what we're doing here, follow it, just subscribe. And then if you think this will benefit a friend of yours, please share it. Thank you again for tuning in, and I will see you at the next episode.